learned there's really no association. People tend to think milk and other alkaline products will help neutralize acid. But in reality, anything you eat or drink is actually going to neutralize acid. And if you look at what happens, some people's reflux or acidic related symptoms get better immediately upon eating. That's because you take the pH of the stomach from being very acidic and you actually neutralize it. And then it's really half an hour, 1 hour, 2 hours after the meal where you actually get the reflux.
Can you clarify why people get diabetes if they're not overweight and if they don't eat a lot of sugar? I still don't know why people get diabetes if they don't have genetic factors, they don't eat a lot of sugar.
So there is less identified genetic factors that are actually underappreciated genetic factors that are still have to be elucidated right now about various subtype of type 2 diabetes, in which it is not based on a certain weight. The general trend, though, is with obesity, with rising weight, it causes an insulin resistance problem that then leads to diabetes. But that's clearly it's not the only thing going on. And so in those folks, it's a insulin resistance problem still, but not because of weight.
And not also if you overload on sugar, because I keep hearing don't eat too much sugar, but does that really
Cause diabetes? No. Eating sugar does not cause diabetes insofar as lots of sugar then will cause you to gain weight.
What's the rate of recurrence of ferritin?
So it's been around, that's a good question. The recurrent rates, this technology was FDA approved in 2006. So the longest study we have right now is 5 years. In 5 years, 92% of people who had it eradicated were still free of ferrets. So that's as long as we have, 5 years.
Since there's 3 million people that have ferrets, I assume that you're only going to be avoiding moderate dysplasia.
Correct. Right. If you have dysplasia, you're a candidate, depending on your overall health status. Meaning if you're otherwise healthy and you think you're going to be around for a long time, it's worth undergoing this procedure. If you don't have these changes called dysplasia, if you just have regular Barrett's, which is what most people have, then the two groups of patients who we consider it are patients who have a family history of esophageal cancer and somebody with a very long segment of Barrett's esophagus. The pictures I showed you were just like a few centimeters. There are patients who have 8, 10, 12 centimeters of Barrett's. But the vast majority of people who have Barrett's anywhere in this country in particular do not need the ablation.
Yes, this question is for Dr. Smollers. The Koreans consume large amount of carbohydrate, and they tend to have a high triglyceride. Is there any correlation between the triglyceride and the glucose?
Yes, absolutely. Actually, the carbohydrates are metabolized into essentially triglycerides. In fact, one of the secondary causes of high triglycerides is high sugar, because sugars are temporarily stored as triglycerides, and the liver generally stores extra energy and then turns it into triglycerides as more storage. And so a high simple carbohydrate diet will likely lead to high triglycerides in that scenario, especially with high blood sugar as well, which is why the avoidance of simple carbohydrates like white rice, white bread, simple carbohydrates like that, in place of more fibrous carbohydrates like brown rice that has a whole kernel and higher fiber foods improve that.
Are there any other questions? If I might ask a question myself. Oh, sorry.
Is the pulse the most comprehensive end-of-life directive for people with disease? Is that the current trend? Because I was just wondering, you said it was new.
There's a national trend. Each state have their own laws on advanced care planning. So there's a national trend for states to adopt pulse legislation and have the pulse form out there. So it's not yet legal, so to speak, in New Jersey. It's legal in New Jersey once the governor signs it, but we'll have already this up and running pilot. But I think it's going to have a big impact in New Jersey, particularly with all that cost and you're going to be hearing more and more about pulse in the newspapers, in the medical literature, because it's a good tool, and it's just that, it's just a tool to align goals of care with available therapies, whether those goals are more palliative, hospice-like care, or full therapeutic efforts to prolong life and artificial nutrition, hydration, and so on. So it's really just a mechanism for doctors to ensure that patients are getting what they want and not getting what they don't want.
So for those who are making up living wills, how specific does the doctors want the advanced care planning so that it is easy?
How specific? It's such a good question. So a lot of these, I hope if there are any attorneys or lawyers in the audience and they don't grow any food, sadly the responsibility of written advance directive has fallen to attorneys, and you go to your attorney and you have your plan your estate or you do your finances, and there's a very generic form that they use with a lot of legal mumbo jumbo that just reads, if you're ever in a persistent vegetative state, make you comfortable. But often that doesn't apply to the clinical situation in the hospital, and you pay a lot of money for these things and they just don't apply. So I'd encourage you all, when you're filling out these forms, to talk about these things with your doctor. So these things should be discussed within the context of your own illnesses, your prognosis, and your own values and what you would want and not want. A doctor has to have some input. Understanding that the doctor is not reimbursed for this, and the doctor is going to shut you out of the office because they've got to get on to see the next patient. So there's a time issue here. Sadly, doctors can't get reimbursement for this kind of counseling, but you've got to squeeze it in somehow. You've got to bring in the advance directive, show it to the doctor, and say, at least say, hey, what do you think of this? And so doctors really need to have, I think, a hand on the written advance directive. Anything in the state of New Jersey can be a written advance directive. It just needs to be either witnessed by two people, notarized, or signed by a lawyer. So I could take a napkin right here tonight and write out what I want and don't want, and just have a couple of witnesses, and that's my living will. Right? There is a standard that New Jersey has that you can get from the Department of Health website, and so on. But just use caution when an attorney suggests, a large fee for this 10-page document that the doctors are just going to scratch their heads over. It really doesn't need to be so complicated.
I'd like to ask a question, if that's okay, about palliative care. I know it's a relatively new specialty, and in a recent experience my family had, it seems that within the medical community there's not an agreement about how to deal with that, and that people might make a decision and medical personnel want to work against that as a specialty. And I was wondering, do you have problems in the hospital where other physicians or nurses are not comfortable with the kind of decisions that
Yeah.
patients make with you?
That's a great question, and it's a long, long answer. I'll try to chop it down, though. I should have told you, I didn't actually formally tell you what palliative medicine is, and there's a big misconception about palliative medicine, the definition of palliative medicine. Out in the community, and even within the hospital, within the medical staff, a big misunderstanding. Palliative medicine is often associated with just end-of-life care, folks who are dying. But the palliative medicine, when we get board certified, when we study this stuff, the topics within palliative medicine just fall into one of two categories. Either symptoms management, we learn how to treat symptoms, pain, nausea, insomnia, things like that, or communication skills. We learn how to have these kind of discussions, advanced care planning, sharing bad information, conducting family conferences, and so on. So you've got to ask the question, when did this stuff leave the general medical curricula? It's kind of sad. It's sort of sad that in this evolution of modern medicine that we need this subspecialty, that doctors have to get board certified in this stuff. Really, it's just bread and butter medicine. And so my point here, this is a very important point, palliative medicine is really just a doctor or staff who focuses on getting that sick patient feeling a little bit better and talking about their goals of care and advanced care planning in the context of their illnesses. And I have to point out, I think Dr. Yi really appreciates this. And I have to mention, and I don't know if you know this, but when I first started at the hospital, Princeton Medical Center, and maybe you have to tell me how long ago that was, but the very first palliative medicine consult that I got at the hospital, that's about 6 years or so ago, was a patient of Dr. Yi. I get this call, I hear this guy, Dr. Yi, on the other line. He sounds like a nice enough guy. He says, I need some help, palliative medicine. I've got a patient here who has a cancer syndrome, a lot of nausea, can't keep any food down, really struggling with the care. Has been in the hospital for a month. And I went to see that patient, and there was a lot we did at the bedside to help her get feeling better. She was out of the hospital maybe a couple of weeks later. Still took a long time. That patient is still alive today. Still alive today. And what did I do? I just helped that patient feel a little bit better, get back on our feet, get back for more chemotherapy, and so on. So that's a perfect example of what palliative medicine is. And sadly, there's this misconception across America, across the medical community, that you wait until the person's dying, until everyone exits stage left and all the subspecialists and then you call the palliative medicine guy. And so what we're trying to do nationally is move palliative medicine more upstream in the course of illness. So when you have the diagnosis of cancer or a serious life-threatening problem, then you meet the palliative medicine doctor or you get a palliative medicine consult earlier in the course of the disease so we can help manage symptoms, help you feel better as you navigate through this process. So it's a big problem. This is often discussed. I hate the name. You hear the name palliative medicine and you go, oh gosh. We actually support, this is actually a marketing gimmick, I confess. We changed the name of the consult service at the hospital to supportive care. And it just, because that's more of what we do. It's a supportive care consult. We help support the patients move through. And it feels better saying it.